into dental hygiene world, and your group here is probably wondering where to get the best sample for a slide, right? So all looks good, but what we don't really think about is how wide this corridor is when he's smiling, that we've got this big chute of empty space going back. And then we open the mouth and we think to ourselves, that's weird. And we never think about what is really happening here. This person has zero airway. I looked at, I think, probably 10,000 throats in my life, and I never saw an airway until 2014. But this is the airway. And if we can't see it from here, it is blocked and interfering with this person's, at very minimum, quality of life. And then we could look right here and think, that's weird. You know, I wonder, is that a tongue tie? I wonder how that's affecting him. And then you look here, and this, especially on this right side, all of his teeth are tipped in. His tongue is wider than his arch. How did that happen? Where did that happen? When did that happen? And look at the palate. In the old days, I would say, did you suck your thumb? And then they would say yes or no. And I would go, well, I'm glad that's over. But this narrow palate and this really wide alveolar ridge are pathologies that we never think about. And then what are we going to do about that? This whole scenario came from a low tongue posture. If we look backwards in time, and I think we should, we will see what exactly happened and when everything happened. When we look at our people who were in World War II generation, they would lose a tooth, they would get a partial denture. They would lose another tooth, they would get a bigger partial denture. Then eventually they would get full dentures. By the time the baby boomers started to come around, we were not only doing endodontic procedures, but we were placing implants to replace missing teeth. And at the same time, we were doing serial extractions for orthodontics. I was born in 1958, and there were a lot of kids in my high school that were full of braces, and a lot of them had 4 premolars removed. So I don't know where this came from, but somehow we kind of figured, they have too many teeth. It's never been proven that people have too many teeth today. It's never been proven that we should have fewer teeth. It's never been proven that taking teeth out is safe and effective. By the time my kids were in school, serial extractions were exceedingly common. By the time my grandchildren came around, or this kind of space in between, the entire diet changed to being chewing optional. There was no reason to chew any food ever. Then we started with these kids who are now maybe encroaching onto their 20th year, maybe starting from 11 years old. They absolutely do not know the difference between food and something to eat. They can go weeks and weeks and weeks and never even eat food. The way that we have been treating food over the last 100 years or so, 150 years, has changed it to be something that is unrecognizable by the human body even. And now we have whatever happened during COVID, where mouth breathing is exceedingly common. Mouth breathing has been on the radar of dental hygienists for a long time. Anybody else get this one? If your patient is breathing with their mouth open, you will notice that they have red gingiva on the upper anterior teeth. If you see that, you are to ask your patient, do you breathe with your mouth open? And if they say yes, you were supposed to say, don't do that. So there's not a lot, there's not a lot of place to move with that. So we've got these kids that are sick with very late stage disease expressions at a very early age. Chronic lifestyle diseases are in these little 4 and 5-year-olds. We have their siblings with an increase in ADHD. Autism numbers have been incredibly quickly increasing. Not only is 60 the new 40, but 20 is also the new 40, where kids at age 20 are suffering the same kind of problems we used to save for 50-year-old, 60-year-old people when I was a kid. We started folic acid supplements in order to solve the neural tube deficits. We started adding folic acid to all grains. All food with grains has this folic acid supplement. And right now, the big question is folic acid the reason we're seeing so many tongue ties as opposed to folate, which comes from actual FOOD. So I know that you guys know to switch all your patients to actual food, but I think what's been happening is that we're trying too hard to make it easier so that they're getting food and it's still not food, it's still highly processed. Patients are in my age category, a lot of them have diabetes. They are on an average of 9 different medications. So what is it that we can do? What can a dental hygienist do before conception? What is happening? What can we contribute to? So there's a whole movement right now called the first 1,000 days, and it starts at conception and goes to about 2 years of age. So let's just talk about conception for a few minutes. We humans in the United States in particular, and other countries are following our lead, have been on a fat-free diet for a number of generations. The fetal development of the brain requires saturated fat. The myelination of all of the nerves in the brain require fat in the diet. Your body will not ever make enough fat to grow a brain. It needs to have fat in there. Human milk is very high in fat. Human infants are born into ketosis. They are not born into ketoacidosis, but we need to help our young women patients understand that it's the 3rd generation of being on these fat-free diets that are interfering with their ability to conceive and to have a normal, healthy infant when on the other side of that. It's a very scary topic, but it's part of what we can contribute to overall health in the United States. The tongue, if we remember back from our embryology classes, separates from the floor of the mouth at about 12 weeks with something called apoptosis or apoptosis. I like apoptosis because you get to say pop. Apoptosis is programmed cell death. So the tissue between the floor of the mouth and the base or the underside of the tongue starts to dissolve, and then the tongue becomes free. And if it doesn't become free, if there's anything that interferes with that programmed cell death, you end up with a world of hurt, as it turns out. We're very much in the beginning stages of understanding how and why this is happening and the outlying consequences of having a tongue that isn't completely free. In the womb, the baby is practicing pretty much every single physiological activity, including swallowing and tasting. They're moving around, they hear things, they're touching things, their eyes are focusing and unfocusing, they're blinking. Most of us who have had children, if we've had children, we know what this feels like. This is part of the practice. They're squirming around in there, they're kicking, they're doing almost everything. Their heart is beating. They're tasting what the mother ate in the changes in the amniotic fluid. They're pooping and peeing, they're doing all of those things. What they're not doing is breathing, and they are not really truthfully smelling. They have triggers from the amniotic fluid that'll trigger different parts of the olfactory nerve, and that looks like smelling, but they're not using air to smell, and they're not breathing using their nose. At birth, the body is covered in this gooey, sticky, waxy vernix, and it will be discovered that the vernix is a growth medium to pass mother's skin microbiome to the baby. So imagine what's been going on is that the mother is giving birth mostly still in a hospital setting. The baby is squeezed out and wrapped up in a blanket and then taken to a light to be placed in a warm medium. They're basically wiped off, and then they may or may not be placed back onto the mother. That whole sequence of removing the baby, removing the baby from the mother and put into some kind of an incubator is, even for temporary, is interfering with one of the biggest, most important physiological things that happen to a newborn, and that is the breast crawl. If you take the baby before you even remove it from the umbilical cord, or cut the umbilical cord and put it onto the mother's belly, the naked belly, that baby will work its butt off to attach itself to the breast. Between the microbiome and the smell of the nipple, and the nipple is dark, and it's very obvious that you don't really have to have a lot of good eyesight. You can just target that big black circle and the baby will get there. That crawl is part of the development of the craniofacial respiratory complex. They did have breast crawl videos on YouTube for a while. I can't seem to find one again. I think because the naked boob was showing, so then they took it down, because heaven forbid we should know what that is. Skin to skin in the first 3 days helps to calm the baby, helps the baby to cry less, releases hormones that relieve stress and stabilize the baby's temperature, breathing rate, heart rate, and blood sugar. It's really, really important. It doesn't have to be the mother's skin. It has to be skin to skin. The colostrum, which is the first milk, comes more robustly when the baby is attached onto the mother with this skin to skin. There are certain tribes, there are certain, I don't know, I almost want to call them backwards tribes, because they have not been infected with this new way of doing things. They will leave that vernix on the baby for 48 or more hours before they start washing the baby. That's how important they think it is. The skin to skin will help the baby gain weight faster, but we're really seeing that this is starting to be a thing that is not naturally occurring. We've been interfering with this for a long time, and it's starting to show up. Babies need to have their lips together. What we're seeing is common, not normal. When you see new baby pictures on Facebook, so many of them have this open mouth posture, when this is what we really want to see, this baby on the left. This is normal. This is common. Who is going to go onto this Facebook page and say, ma'am, your baby is chronically sick. They're going to be having high blood pressure. They're going to have crooked teeth. They're going to need braces. Their eyesight is never going to develop appropriately. They're going to have anxiety for their entire life, and they'll probably have sensory disorder in their mouth, and they won't eat actual food for a really long time. Who's going to sign up for that? Nobody. You're just going to say, oh my God, he's so cute. Oh my God, he's the most adorable baby ever, or she. When we really need to have these lips together. And we need to start adjusting our language a little bit and really just addressing this part as the craniofacial respiratory complex instead of the craniofacial complex. We have to add this respiratory part, and this is our department right back here. I just wrote a little booklet on for new parents to talk about what's going on behind the lips and what growth and development looks like and what they should be expecting when they are looking at their new baby. We already know that the brain increases the top of the head, the size of the top of the head. There's almost a billion neurons and synapses that occur almost every minute in a newborn. The mandible will grow as led by the midface, particularly once the teeth come in. And the midface grows to tongue because of tongue position. That is the missing piece. When you think back about that patient I showed you right at the very beginning, how his palate got so tall is because his tongue was never engaged fully into the maxilla. It was never pressing up in there. When we're looking at these infants, we have to think about the craniofacial respiratory complex. This here is an escape hatch. Something's wrong with this baby up in here that's making the mouth open, because this is normal with the mouth closed. The mouth is for nutrition acquisition. It is not for breathing. There are no physiological benefits to breathing with the mouth open. The only reason it's there is if you fell and you were still wearing no shoes and a loincloth, you would fall, land on your face, your nose would swell, and you could still breathe with your mouth. That's the only reason the mouth is there with respect to breathing. With respect to chewing, we're way behind. Modern chimps spend 6 hours a day chewing. Nobody wants to sign up for 6 hours a day chewing. If you're going to be on a plant-based diet, you're going to have to devote more time to chewing because the nutrition is just not enough in plant material. Modern humans spend now about 45 minutes, which is not really just not enough. We're using tools to take care of the food so we don't have to chew. Being upright created a smaller birth canal in humans, which forced the birthing of that child to be far earlier than any other mammal. The baby's head was too big to pass through the birth canal in any other way. Sapiens have one of the largest body to head size ratios, and it's forced them to be born much earlier than they could be, which means that they're so dependent, they can't do anything. And I think we all know they can't hardly even open their eyes, right? They can't hold their head up. Chimps can hold onto their mothers by about 2 months. Modern babies, they take forever and then they never let go. Human babies, first 7 months are as though they were still in the womb, completely helpless. And carrying a baby around would be extremely calorically expensive. According to this book, Who Ate the First Oyster, the best, most important, what do I want to call it, a tool that was ever created was a sling for the infant, because that allowed the mother to contribute more to food gathering and contributing to the whole tribe. Breastfeeding, I'm very, very sad, and this probably could be what sets you guys apart from the rest of the hygienists in the world. The American Dental Hygienists Association does not have a white paper on breastfeeding. They have nothing to promote breastfeeding. I think it would be really cool if the IAOMT hygiene group came out with a white paper on the benefits and developmental benefits of breastfeeding for as long as possible. There's an intricate, powerful interaction between mother and infant. And if that is interfered with because the tongue is restricted in any way, it's big, it's huge. The human brain, the mother's human brain, the human brain of an adult female that just gave birth is completely rewired to only focus on the survival of the infant. There is very, very little, anybody who's had a baby in this group can probably vouch for the fact that you lose a little bit of your brain with the afterbirth and you really just can't really think. There's just a bunch missing. And that is because everything else is focused on making sure that baby's alive for another day and another day and another day. And it's really important that we get into tune with that and really start to promote this breastfeeding thing. Breast milk cannot melt teeth. It is evolutionarily inconsistent to think that breast milk is going to destroy human dentition. It's just not going to happen. This word right here, the dyad, is really critical as well. The dyad is a term, a sociological term of a group of two people. In the mother-child dyad, we have all kinds of other things happening that we need to use this term a lot and really honor this idea that there's a mother-child interaction that's over and above what other two people have. And we need to know
if your baby doesn't attach properly, she may not take enough breast into her mouth. Your nipple will rub against the hard part of her mouth at the top. You may get sore, and your baby may not be able to take enough milk from the breast. She may seem hungry all the time or not gain weight. Also, a buildup of milk in your breasts can be a cause of other problems, like mastitis. You can avoid difficulties like these by ensuring that your baby attaches well at the breast. To do this, bring your baby's nose directly opposite the nipple. Then let her head tip back a little so that her top lip can brush against your nipple. This should help her open her mouth. When her mouth is open wide, bring her to the breast with her head tilted back and chin leading. Your baby can then take in a large mouthful of breast, not just the nipple. The breast will be drawn deep into her mouth, so your nipple will go all the way back to the soft part of her mouth. Your baby will be able to take all the milk she needs, and you won't get sore.
So all of us could learn just that so that we can be supportive. I think it'd be really cool if you guys all had a lactation consultant come and do a lunch and learn at your office so that you can help support breastfeeding in your age-appropriate clientele. Even if your clientele is older, the grandparents can have a very big impact, especially if it's their daughter who's having a baby. A lot of times something happens and the baby needs to be fed with a bottle. Either it's breast milk, which is fine, or formula. What we need to do is make sure that all of those pieces are still together. This posture for the infant and how the mouth is working on a plastic nipple or a non-human nipple should be very, very close to what it is like in breastfeeding. We want to have the lips flanged out. We want to have the tongue moving up and down to bring the fluid out of the bottle, because all of those things together will help form that craniofacial respiratory complex. Where's the dyad in this picture? The baby has to be held in the arm. This baby here is just bare naked, hanging out there. There's not enough touching of the skin.
In order for effective breastfeeding to occur, a good latch is required between the infant mouth and the breast. An effective latch requires a few things from the infant. The mouth is widely open with lips that are flared or curled out. The tongue is extended over the gum and under the nipple. The nipple needs to be fully inserted into the mouth, including some or all of the areola. If any of these factors are missing, breastfeeding may become ineffective. Symptoms for the mother include prolonged feedings, painful nipples, and decreased milk production, while infants may exhibit noisy suckling and gas pains. A normal infant tongue has good mobility. Tongue tie is when the tongue is stuck to the floor of the mouth, preventing adequate mobility, which leads to an ineffective latch. The tongue tie may also be hidden under the mucosal lining, a condition called posterior tongue tie. With tongue tie, the tongue tip does not extend over the gum, causing the newborn's gum to chew on the nipple during feeding. Also, the up-down motion of the tongue is hindered, preventing an adequate suck, resulting in decreased milk production. A surgical procedure called tongue tie release can easily correct this cause of ineffective breastfeeding. Upper lip tie is when the newborn's upper lip does not curl up or flare out enough, resulting in loss of suction and the nipple to be incompletely engaged within the mouth. A surgical procedure called upper lip tie release can easily correct this cause of ineffective breastfeeding.
There's also a new Facebook group called RDH to IBCLC. IBCLC is an international designation for breastfeeding and lactation consulting. You can, as a dental hygienist, become an IBCLC. None of their paperwork will reflect that, so you have to be a little bit dogged and you have to just keep asking questions. But this group has a number of people who have made that transition from clinical dental hygienist to IBCLC. This is a master's level education, so it's not slouchy. That's how big a deal this thing is. So what about weaning? What about chewing? What's happening here? When you put pureed foods onto a spoon, what happens to the muscles in the baby's face? So this is, I'm just gonna let this play here. This is baby-led weaning over here on the right. This is the baby's very first time with solid food. And then on the left, you're gonna just see a compilation of the funniest baby's expression. But you can see that the baby doesn't know what to do with it. They don't know what to do with a spoon. They don't know what to do with the mush. When the baby puts the food in their mouth themselves, it's partly a game. And they're learning and they're exploring. The tongue needs to work in a particular way, which we all learned about in our clinical dental hygiene education, and that is to undulate backwards, to propel the food back into the throat. So when you're giving a puree, it scatters throughout the entire mouth, and the tongue doesn't know what to do yet. The mechanics of food is equal in importance as the nutritional content. So one of the really cool things that I heard from Dr. Robert Lustig and from Dr. Kevin Boyd is this term nutrition acquisition, which is chewing. It's not like going to the grocery store. Dr. Barry, what's his first name? Is it Ken? He has a few videos on red meat for infants as part of baby-led weaning. We need to get those components so that they get good brain development, good facial development. Instead, we are giving these purees and we're putting food into our body that is never chewed. We've seen a really big decline in the amount of food that is chewed, the amount of chewing cycles, the amount of minutes for chewing. mostly because the food is so overly processed that you don't even need your teeth. And when that happens, that information is translated epigenetically into the next generation. You don't need your teeth. You don't need a big wide arch. Your tongue is fine. You hardly need it. You don't need to chew your food. There's plenty of food that you can drink. We're putting a 40-minute salad into a blender, and then we're drinking it on the way to work. We're counting on the fiber because the fiber is supposed to be good for us and blah, blah, blah about fiber. But when you put it into a blender, you're turning it into sugar, and you're creating a blood sugar spike from drinking a salad. It's absorbed as quickly as regular table sugar once it goes through a blender. And because that's happening, we are finding that we are having many, many consequences that we are at least wondering about what happened over here in the lifestyle and maternal age and all of that stuff over here. This woman is pregnant with a girl baby, and that girl baby is growing all the eggs she's ever going to have. And she's carrying information on the DNA in that germ cell based on the environment of the mother. So when this germ cell becomes a human, whatever happened to that germ cell's grandmother is what's being reflected in that person. Here's a really good example. The annual new onset of pediatric type 2 diabetes, which was unheard of up until maybe 20 years ago. And since COVID, it's going up like crazy. And I think we all kind of know that this is happening, but nobody's doing anything. Nobody's saying, stop eating junk food before you get pregnant. Because all of those years before you're pregnant is getting translated onto that DNA of that upcoming human. And so we need to be more cognizant of less sugar, whether it comes from bananas or whether it comes from lifesavers. It's still coming on as sugar, and we're using surrogates as measurements for insulin. We're measuring the glucose in the blood, not how much insulin is being made or being used. The other thing that's happening is this incredible uptick in type 1 diabetes in adults. That means that the pancreas has shut off. We used to call this juvenile diabetes, but we're seeing so many adults come out with type 1 diabetes that we're really in a quandary right now. COVID infection seems to increase the expression of type 1 diabetes. They're calling it type 1.5 for some mysterious reason. So that is happening too. If you're not doing blood glucose testing in your office, I would strongly suggest that you start doing so. It's going to answer a lot of questions for you. So the food that we eat, the way that we have the food, the distance between your mouth and the food originally is incredibly important to the facial development. Who's going to tell this baby's mother that his face is wrong? Nobody. You're just going to say, well, you're going to have to save up for braces. Once you start doing baby-led weaning, you're going to see that more and more of these changes can be mitigated. The baby will take at least 1 hour to muscle their way through food. Baby-led weaning should start at about 6 months and then just continue to go more and more. The majority of the nutrition comes still from breastfeeding. So most of this is toys that accidentally get swallowed. Hunter-gatherers were taller and lived longer than their farming brothers. So we need to make sure that we are getting meat into these babies. Fructose is now known to pass through the placenta and start a fatty liver situation in a newborn or a preborn. So this fructose baloney, we need to get rid of all of that. This is the Maasai tribe. They are hunter-gatherers. They still live as hunter-gatherers, but their environment has changed so dramatically that they're eating more and more plant material. They used to hunt elephants. They are now banned from hunting elephants for food. They used to hunt other large wild game, and because of urbanization, even in Africa, and we even have a South African lady here today, maybe you can fill us in a little bit, but their diet is also being modified, let's say. We have the counter to that is these ocean island dwellers that almost eat no meat. And they are also just as healthy as those obligate meat eaters from the African places. But what they have in common is that they're not eating any sugar or flour or processed foods and no vegetable oils. Dr. Kenobi has a few videos on YouTube about the increase in vegetable oils and the increase in chronic illnesses over the last, 70 years, 100 years. We've had an incredible increase in chronic diseases ever since we started really piling on these vegetable oils. And then this is about the time right here in the 70s and 80s where hydrogenated oils were preferred. McDonald's went from boiling their potatoes in tallow, which comes from beef, and they started using vegetable oils there. And everybody was suddenly afraid of saturated fat, and all of that turned out to be a lie. Seed oils are all of these. Even if they're organic and cold pressed, they are still incredibly manufactured. Fruit oils are saturated. They are hard at room temp or at colder temperatures, sometimes even on the counter. But these are the oils that you want to have if you have to have oils. Many of you probably know about the Bale-Donine method, which is the crux of the AOSH group, and how inflammation leads to cardiovascular diseases and events. And all of these are the root causes of arterial diseases, i.e. inflammation. But when Dr. Peldiak and I were looking at this and we're like, yeah, but where do seed oils fit in here? Where does sugar fit in here? And he decided that it was like adding fertilizer into all of this stuff down here. If you're exposed to nicotine and you eat a lot of sugar and you use only canola oil, you are adding fuel to an inflammatory problem that's coming up. Natural selection is no longer valid. People don't die anymore because we have such good health care for emergency kind of situations. Most of us know at least 10 or 15 people that would have tipped over if it wasn't for, or never been able to have a child even if it weren't for interventions in medicine. And part of that is because of the way that innovation works. So let's just take breastfeeding, for instance. In the time before time, if a baby couldn't nurse, the baby would die. Period. Heart-wrenching as it sounds, impossible as it sounds to leave your baby just crying in the woods somewhere, that was the life. Then somebody said, well, it doesn't hurt me as much as it hurts you. Let me give it a try. And they started wet nursing. We even have pictures or woodcuts or whatever of wet nurses holding infants under like a goat. And they would then feed right from the goat. Eventually, we started with formula and bottles. The baby started to gain weight. The baby survives. Everything's right with the world. Or is it? The child develops. And now we have these incredible weirdo diseases and conditions in these children. Who is going to tie that back to this? It's been really hard to make any proofs of that, which doesn't mean that the proof doesn't exist. In the super olden days, in the time before time, humans would scavenge carcasses. We would fight with hyenas and eat the leftover proteins that were killed by lions and other larger animals. Once we harnessed fire, the foods were safer, and we found that, well, we didn't find, but it turned out that it released more nutrients, and we were able to grow our brain much quicker than ever before. And then we co-evolved with other animals so that we were able to make use of scraps easier. And then we started with the farming. And then we started to have improper balances between this and that. We would store grains, and then we had to fight the rats. And then the rats would leave poops around, and then they would infect a lot of different things. Stored grains go rancid very fast because they're exposed to air. We had wars that came on partly due to farming and having a large group of people living together. Hunter-gatherers scavenged for food, and they traveled. Eventually, many of them turned into farmers when we started to see a lot of illnesses starting. The first dental decay that we see, substantial decay in dentitions, didn't occur until after farming started. We started to have pestilence. Now we have antibiotics, and we have tech to help us live in these large communities. And then we have interferences with a lot of this. There are dark forces at play that nobody wants to talk about. Everybody gets a big eye roll and gets conspiratorial, but they're out there. The governments have decided that subsidies were going to be important. And then we have power shifts that keep us not being true to what is really happening. Foods don't cause decay back then. In the time before time, the increase in carbohydrates about 10,000 years ago is where we started to see decay starting. Fluoride made even less decay. And now fluoride is ubiquitous. How many more teeth were saved? We don't know, but suddenly fluoride's not working either anymore. Nobody ever adjusted the diet. Back here, before we started to really put fluoride into everything, dental decay in a child was an indication of diabetic. That was their first indication that the child had type 1 diabetes. That is part of the problem today, I think. So then we're sitting here and we're talking about eating the rainbow, and plant-based diet, blah, 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 all this stuff, when this is what it's turning into. This was an actual post by an actual dental hygienist talking about her powerhouse every morning out the door. I messaged her privately, and I was like, there is no food in that picture. Oh, Shirley, it's really food. You just don't understand how much effort and how much they put into growing this food, and it's so amazing, and all the stuff and everything like that. And I was like, what is happening? What is happening? How is this not processed food? It's happening to our DNA. We now see things that are so common that we now call them normal. I had a mother in here with her 15-year-old son. She said the ENT said it was very normal for a 12 and 13 and 14-year-old boy to still be wetting the bed. That's where we're at. This is insane. Dr. Kevin Boyd has been doing a lot of research on fetal skulls and how they have changed over time. And what he found is this retrognathic mandible is not normal. It may be common, but there's no proof to say that this small degree of retrognathia helps the baby come through the birth canal. He is not finding anything. He's gone globally to archives of fetal skulls, which I'm sure you can imagine that they're a little bit tricky to find. There's not a lot of ossification, but no baby chins are in a retrognathic kind of a situation that he can find in the pre-industrial times. Once you get, so this picture here, this skull here on the right is this x-ray of that skull. And you can see the angle of the mandible right here. And then this is what we're seeing every day on these sonograms. No chin, no chin, no chin. Who's going to tell this mother something's wrong with her baby? No chins. Back in the 1940s, after Dr. Weston Price did his global tour and showed how the mandible and the face changes with processed foods, Dr. Pottinger did a similar kind of exploration using cats. And he fed a prescribed diet across generations. I think there were maybe 6 times. He gave each generation the same food, the same diet. Each cat had, no matter what group they were in, had a diet of a species-specific nature of raw meat, raw bones, raw milk, and then 2/3 of the diet was manipulated. So they had things like sweetened condensed milk, they had cooked meat, they had cooked bones. And in the first poor nutrition group, we can see what damage happened skeletally. Nothing went back together. There was a lot of damage in the cartilage. There was a lot of damage in just the formation of the skull. And by the 3rd generation on the poor nutrition, it was terrible. The cats were super sick. They couldn't conceive. They had fractures. They had dental problems. They had asthma. The inability to reproduce was very high. A lot of stillborns. First allergies, first asthma was detected or reported in this group, in the poor diet group by Dr. Pottinger. It took 4 generations on a species-specific diet of raw meat and milk to get these cats back to physiological normalcy. 4 generations. Where are we now? We're probably in the 5th generation right now of this fat-free, don't eat meat, saturated fat is dangerous kind of diet. We're eating an anti-species diet. We're eating foods that don't match our DNA. I'm from Northern Europe. My people 10,000 years ago have never encountered a banana. They've never encountered a pineapple. They did use cabbage. They did eat foods that were not found on the equator. If you are from an equatorial place ancestrally, you can get away with these kinds of foods. My mother loves blueberries from, I don't know where she gets them from, Chile, all year round. And I'm like, why are you eating that? But let's remember that she was living a pauper's life in a small community in a small German enclave in Hungary. They didn't even have cars until she was repatriated after World War II. That's how backwards they were and how ancestrally they ate. So she now is a little bit more tolerant of all this stuff, where I am just terrible. I can't lose this weight. Nothing I do seems to matter. I have an anti-species lifestyle where I don't move most of the day. This is problematic. We need to be doing better. We're telling people to eat a plant-based diet when every food is full of glyphosate. Even all the wines in California have glyphosate levels. We have, salmonella recalls all the time from these vegetables. We almost never have a salmonella recall from meat. And we talk about the phytonutrients. They are in the fat of an animal that was grazed ancestrally and species specifically. This was what Dr. Lustig calls insulin resistance in the cow. And this is what we see in meat that has been raised humanely. This is a cool little video.
The sweet smell of fruit doesn't normally send rats running, but when researchers paired the orange cherry almondy scent of the chemical acetophenone with a painful electric shock, lab rats quickly learned to fear it. Along the way, extra neurons sprouted in their noses and in the smell processing center of their brains, making them super sensitive to the scent. This result isn't shocking. What is surprising is that the rats' pups and their pups' pups were also startled by the smell of acetophenone and had the same extra neurons as their fathers, despite never having been introduced to either their dads or the fruity scent before. But how could the pups have inherited something that their fathers learned? Basic genetics tells us that only DNA gets passed along to offspring. Characteristics like memories, scars, or giant muscles can't get passed on since acquiring them doesn't alter the genetic code. But it turns out that instilling fear in the rats did trigger genetic changes, not in the DNA sequence itself, but instead in how that code was read and used in the rats' bodies. In every cell, biological machinery constantly translates DNA into the proteins needed to carry out vital processes. Chemical switches attached to the DNA turn genes on or off or up and down, telling the machinery which proteins to produce and in what quantities. These switches, called epigenetic tags, are why a kidney cell looks and acts differently than a skin or nerve cell, even though all three cells have identical DNA. But the switches in any one cell aren't set in stone. Teaching those rats to fear the fruity smell switched one of their smell-sensing genes into overdrive. Researchers don't know all the places in the rats' bodies where this switch got flipped, but they know it happened in one key set of cells, the rats' sperm cells, which would one day pass along the tweaked genetic material, making the next generation of rats super sensitive to acetophenone. Rodents aren't the only creatures demonstrating this weird type of inheritance. In Orofacial, Sweden, boys who suffered through tough winter famines went on to have super healthy sons, with extremely low rates of heart disease and diabetes. And their sons had the same excellent health, living an unbelievable 32 years longer on average than the grandsons of boys who hadn't gone hungry. To be clear, this does not mean that we should start starving our kids for the benefit of future generations. Scientists don't even know yet exactly which switches the Swedish famines flipped. While we have been able to connect specific epigenetic changes to health effects in mice, we're a long way off from being able to make those connections in humans. That may sound like a bummer, but it's mostly because we humans don't live in the well-controlled environment of a laboratory. And for that, we should be grateful.
So, and this is what's been happening. Her nose, no chin, surgical intervention. Still breathing quietly. Mouth is still open. Still has little dark circles under his eyes. They're saying that almost 60% of tonsils and adenoid removal is a temporary situation, that the patient will go back to mouth breathing and snoring. We need to do better. We need to do better. Our brains are bigger, and we're losing a lot of what it was that made us unbelievable, because our food has just really gone downhill. Oral breathing does change the face, and we have even codes for anticipatory guidance. We can do this for our infant children. We can do it for pre-parents with who are going to have a baby, and do some kind of education on what it is we should be looking for, and be breastfeeding as long as possible. It's not the milk. everybody is all about the milk, and it is about the interaction between the mother and the child with the breast in the mouth. We need to really focus on the development of this craniofacial respiratory complex. Make sure that everything grows together. Dr. Boyd is now on a mission to use the term early childhood malocclusion, and that the ideal time to treat that is before 72 months. He says that transverse growth deficiency will never self-correct. Retrognathia will never self-correct. The bimaxillary retrusion will never self-correct. Retrognathia may be that the maxilla is just deficient. It may not be that the mandible is forward or backwards. It may be just that the maxilla is in the wrong place. The tongue doesn't grow after age 7, he points out. It can become edematous, it can accumulate fat, but it's not going to grow. So the tongue that I showed you in that patient in the beginning, where his tongue was so wide, is just not, it's always been that way. We can do better and be more aware of what's happening for that patient and do something earlier. Dr. Boyd also has this Chicago Hearts idea. And these are all the things that can go wrong and should be raising red flags. So he is a pediatric dentist, so that's his perspective. I'm gonna go through this very quickly. You can take a screenshot of this right now so that you have kind of a framework. Anterior, or any kind of a crossbite. This is an anterior crossbite, obviously. Which is it? Is the mandible forward or is the maxilla back? We don't know. A posterior crossbite is also a big red flag, any crossbite. Hyperdivergent facial pattern. That is super narrow and super long. You can see it on the x-rays. You can see it just looking at them in the face. Hypertrophic tonsils and adenoids is another one of the H's here. When you see this is a problem. I mean, obviously we know that now, but this was, that's weird. And then I would move on, we need to do more. Incompetent lips. If the patient can't keep their lips together for whatever reason, that's a red flag. Constricted arches, where the teeth are like piled up on top of one another, where they're all jumbled like this, that's a red flag. That's an airway issue. Volume of airway in the throat. Teeth grinding. I don't know any dentist who could tell a parent that their 3-year-old is just stressed out with a straight face. I think every single one of those conversations ended up with some kind of a grimace in the office after the patient left. This is an airway problem, any kind of tooth grinding. In children for sure, and even in adults. Overweight children, when they're sleeping with their mouth open, they're swapping the two hormones that tell you if you're full or if you are hungry. So they're completely kittywampus. This forward head posture here is part of an attempt to open the airway. You can see this child's picture here. There's quite a bit of mass around the airway. A shallow palate, a highly vaulted palate. Both of those, we want to see a shallow palate. We don't want to see this highly vaulted palate. You can see that already in a little tiny kid. Modern day palates are getting smaller because the tongue is not resting up on the roof of the mouth. Eczema. Who would have thought? Kids with eczema are having breathing issues wherever the eczema is, not just on the cheeks. Eye appearance. We do not want to see the sclera showing below the iris. Do they have venous pooling? This is stuff that we treat as a myofunctional therapist. Okay, we get the mouth to get closed, and these things kind of resolve. I stole these pictures from a website for plastic surgery. So this person wanted to have rhinoplasty, right? They wanted to straighten out their nose and got that done. But look at what's still wrong here. You can still see the sclera beneath the iris, and you can still see the venous pooling. This person is still not healthy. They're still not breathing optimally, even though their mouth is closed in the picture. We have kind of a mentalis muscle here that's a little bit overactive. Anterior open bite. That is also an indication of a breathing problem because the tongue is restricted in the posterior area. I'd like to draw your attention also to this blanching. They're holding the lip out, right, with the retractors, and now we have this blanching here. And that's a pathology. Something's wrong there. Retrognathia is also problematic. We can see that it's kind of impinging onto the airway here. Retrognathia, whether it's, I guess we can call it retromaxillary. So which is it? How do you know? You really need to take a special kind of an effort here. Tongue posture is really big. If it's not up against the roof of the mouth, you're going to be squeezing this airway down. A lot of people are doing CT scans now. You can get gross anatomy from it. You can't really make too many other diagnostics with it. We've got a classic tongue tie, scallop tongues, septal defects from the mismatch in growth of the maxilla to the top of the head. Remember, the top of the head grows because of neuronal development and brain development. And if the tongue is not lifted and pressing against the maxilla, then you have a mismatch in growth and you have an idiopathic deviated septum. Here's a good example. You can see the tongue is not against the palate in this picture, and this person has an idiopathic deviated septum with no injury. We used to call this the throat, and we have to call it the airway now. It's really important that we use better language. We should be able to see the entire uvula. When I learned about this classification, I thought these people would be on their deathbed in the hospital, but they walk into my office every day. There are now 5 dimensions of a tongue tie, and I would invite you to take a picture of this too. We use the Kotlow free tongue measurement. We want this from here, from the attachment to the tip, at least 16 millimeters. A lot of people have that. Then we take a ratio between the maximum or comfortably wide open mouth with the tongue at rest. Then we do the tongue with tip to the spot behind the upper front teeth, and we get a ratio here, and then with the tongue in the lingual palatal suction posture, and we want to see at least 30% remaining there. So these are super simple things that you can do in your office. And then when you go this next level and notice that there are compensations. So you can see this person here has a ventral funnel. Some people have the floor of their mouth lifting up higher than their the occlusal plane. And then we're also looking for tension in the neck. This is the study that really changed everything for everybody. This was published back in 2020. And this is how you would do the measurements. So I'm just going to quickly go through that. So this is wide open. It's 41 millimeters. Then tongue to the tip to the spot, and then we measure 22 millimeters. And then with the tongue in a suction. And then this one turns into 20 millimeters. So then you do some fourth grade arithmetic. This is 53% remaining. And so that would be a grade 2. And then this is 49% remaining. This would also be confirming this grade 2 tongue tie. This is another way to visualize all of that. A lot of people, if they can't do a suction, they only get a tiny little bit of their teeth apart here. This person here, we've got the salivary duct is kind of lifted, so this is maybe not the best picture of a grade 1. This is a grown adult. You can see they have permanent teeth here. This is, their tongue is tethered to the floor of their mouth. I mean, how do they get to be adults without having that addressed? This is a patient of ours who had her tongue tie released. You can see the blanching is way here at the tip. She still has a little blanching here, but that's a different tongue. These are two separate people, sorry. Lower anxiety, her athletic improved quite a bit. This person here has lower anxiety, performance improvement, and their pelvic floor resolved. This person here was very attuned to her body, and she was in very dire straits. She wanted to run better. She wanted to run faster. She was having trouble with her pelvic floor issues. And after the release, boom, it was done. This person spent 11 years in braces. She's 60 something years old. And you can see that she had braces here too. Couldn't really do a suction at all. And now she has much wider, she still has a little bit retained here of this, but her constipation ended the day she had her tongue tie released. She'd been doing everything, more fiber, more this, more that. This one wanted to be an interpreter. Look at her jumbled up teeth. She couldn't do her R's. And after the tongue tie release, her speaking improved. Her distance between her teeth was greater. She was super happy with everything. If you have any questions, now would be a good time to get them typed in or get yourself ready to ask. This person came to us for periodontal disease. Got his mouth
webinar.
What?
Webinar.
Then again.
Somebody's microphone is open and we're not ready for open mics. So we increased his distance with his suction by 4 millimeters. And when we were finished, all of his perio readings had resolved. Mouth breathing is huge. What do you know about mouth breathing? Mostly you'll know about dry mouth. Chapped lips, lip licking, all of these are indications of mouth breathing, which is one of our specialties, to get our patients to have their mouth absolutely closed all the time so that they can breathe easier. So to do a quick and dirty exam, you're going to do your oral cancer screening, and you're just going to look at different things. You're going to look for sharp rugae, which means that the tongue has never been up there. You're going to look to see if they have a narrow arch and if they have a wide alveolar ridge. You're going to look to see if you can see the uvula. You're going to look to see about the tonsils. You're going to give them an airway score. You're going to look at the attachment of the frenum onto the tongue. How long is it? Where's the attachment on the floor of the mouth? You're going to look to see if there's a divot or a dimple in the dorsum of the tongue, which is an indication that the tongue is restricted at that location. You're going to look for extension. You're going to look for scalloping. You're going to look for a tight attachment up here and down here. You're going to look to see if there's extra growth here or there. You're going to see if their mouth is dry. Is the frenum inflexible? Is their gag overly triggerable? You're going to look for linea alba. You're going to look for scars and flexibility of the other frena. So this is all stuff you're doing anyway. And what you're going to do now is, instead of, that's weird, you're going to make a timely referral to a myofunctional therapist for whatever is the issue. This is our referral sheet. So it kind of gives you a little running list here of things that you might be looking for. This half goes to the patient so that the patient knows what it is that you are referring about. And this part gets emailed to us, and then Philip will call them because they really don't know what they're doing. So instead of leaving it float around their car or the bottom of their purse for the next 8 months, then we can at least get them going. These are the things that I look for. We do a posture assessment, we do the Epworth, we do a control pause, which is a breath holding test. And we just look at pretty much everything that's going on. Headaches, what's their attitude, all of that kind of stuff. And what you can say to them to get them understanding a little faster are a couple of key phrases here that I came up with that one of our top referring doctors uses. We have a new appreciation for the function of the tongue, which is true. We never appreciated the function of the tongue in infancy, which is true, unless you're nursing and it's very painful and you have to stop and give a bottle. That part is never even addressed. Dentistry has had a low bar for tongue tie, and that no longer fits the truth. Can you talk? Can you eat? Next. That's not appropriate. We're going to recommend that you see a tongue specialist. That phrase right there is the thing that really gets patients' attention. It looks like your tongue restriction is accumulating to problems. We get a lot of referrals for TMJ. We get a lot of referrals for caries management, anxiety, ortho relapse, bedwetting. We're going to recommend you see a tongue function specialist before we go further into treatment. If the tongue's not right, nothing else is going to work. Who should be on your team? Everybody. Get a speech language pathologist that does myofunctional therapist, do a lunch and learn. I can do a lunch and learn for you as a myofunctional therapist. Get a tolerant medical doctor, get more dentists involved, a physical therapist, nurse practitioners. Chiropractors are huge. Get your dental hygiene educator friends to start teaching more about the function of the tongue. Get a respiratory therapist. Nursing home administrators, those people are choking on food all the time. Medicare, learn more about that. Medical malpractice people, feeding specialists, dietitians and nutritionists. Many of you are already nutritionists. Healthcare attorneys. Take a patient like this and recognize that there's problems right out the gate. You do not have time to talk about their vacation or yours. You need to get on it. That person is dying every night. They're losing a week of their life instead of just one day. When you see this, this is a big red flag for that patient. When you see this, you can refer them to arch expansion in an adult. This is Dr. Mike Mulligan, who is the past president of AOSH, the American Academy of Oral Systemic Health. He had arch expansion at the age of 62. It took him 18 months to gain 8 millimeters and 3 millimeters anterior posteriorly. He's got little spaces here. I don't know that he ever took care of those spaces. They wouldn't bother me very much. Look at the amount of space he even gained in the mandible. This is possible. This is not impossible, not just by uprighting teeth or pushing them out of the buccal corridor. You can get actual growth at the symphysis here. Not cheap. So we need to get to these people as soon as possible. If they're 3, if they're 7, if they're 15, if they're 40, if they're 70, we can do something. The earlier we start, the cheaper it is. That arch expansion, there are people charging over $20,000 just for the arch expansion on an adult. This is the gadget that most people are using now. This is called the Vivos, in case you haven't seen one. Look at how much space this woman got. Look how much space she gained on the mandible. She's also having braces on top of it. Look at this, her eyes. See how the outer canthus of the eye is lower than the inner canthus? This is a deficient maxilla. It's another key. So this person here, $62,000 to get surgery. $64,000, over $20,000 out of pocket. It's unbelievably expensive. The Healthy Start program is an appliance for children to help grow everything at the childhood level. This is only available through dental offices. We use the Myo Research appliances through Primal Air to help grow that. Let's remember that whatever we're doing is affecting future generations pretty dramatically. And it's real important that we get moving with all of this stuff as soon as possible. If you can't find somebody local for you, we see the majority of our patients online. So we can see them from beginning to end, right? Just like this. So I'm open for questions. I have a patient in 6 minutes.
Thank you so much, Shirley. That was fabulous.
Thank you.
I so enjoyed that. And I know all this stuff, but it's still, to see it again is just wonderful.
It's nice to see a second time, right?
It is. It is. I'm going to go back and listen to this again as soon as Randall has it edited and on the website. So outstanding, outstanding. Thank you so much. So our
You're
questions. Tiffany wrote, so you talk about glucose screening in the office. How much time do you recommend giving a hygienist for a recare appointment?
You can do everything necessary in 40 minutes. Is polishing necessary? What are you doing in your 40-minute appointment or 90-minute appointment that you don't need to be doing? You can go and have coffee with your patient later, but all of this screening is critical. They are expecting excellent care, and excellent care does not mean you know about their vacation or they know about yours. Not you, Tiffany, just saying hygienists in general are not using their time as wisely as they can. And sometimes they'll come back. They will come back. That perio patient that I just showed you did not have a tongue tie release. It was just a feature of getting his mouth closed and performing all of his activities with his lips together, including living at a high altitude.
All right, Tiffany had some more questions.
Some kind of fungus out there. I'm going to spray it.
All right.
I'm sorry?
Tiffany has some more questions, so let me
Okay.
pull up the chat here. All right, so what whole foods are you recommending for your patients? You said meat and chewing is important, but are there specific foods people need to be eating regularly? And do you believe in
Nose to tail meat.
supplementation?
Nose to tail meat. I would like for them to eat all of the internal organs that they can have, that they should have liver every couple of weeks. I'm not a fan of the raw liver that a lot of these people are doing, especially the Weston Price group, but some people like it, so there you go. I'm not interfering with anything other than to say don't come from a box or a can. They should just eat a varied diet.
All right. And then her next question was healthy start. I mean, the
Yeah,
difference
we
between
did
healthy
talk
start and
about that.
myobrace.
Yeah, I am not, you know, you need to take classes in order to use the Vivos and the Healthy Start both. It's pretty expensive and you need a terminal degree. You have to be a dentist in order to recommend or deliver those. So I work with a biological dentist in Pewaukee, which is about an hour from here. She has a lot of kids on the Healthy Start. And then, you know, we can use the T4K and some of the other appliances that that are available to us through myofunctional research out of Australia.
Excellent.
Starting my granddaughter on Healthy Start.
Who's
4100.
talking, please?
Michelle Grout.
Oh, okay.
Yeah.
Go ahead, Michelle.
So I've just taken her for her first consultation for Healthy Start. She's 7.
Super.
But I'm going to wait a little while. It is expensive.
Well, that's the thing, right? I mean, the longer you wait, the more damage is happening to her brain, to her breathing, all of that kind of stuff. And it is very expensive. And I don't know why it has to be that way, but it does. So
We're hoping to start in January. So
yeah.
he said we should be okay.
Yeah. You know, the Healthy Start can start at 11 months, I think, is their first appliance.
I have 2 questions.
All right, go ahead,
Okay.
Melanie.
How do you explain to the patient how the tongue on the palate smooths out that rugae? And then also, are you always releasing the tongue, lip, cheek tie immediately once you see it, or are there cases where you would wait to see if it needs to be released, if the child falls, releases it itself, or if
I never ever say wait for the kid to fall.
Okay.
That's absolutely off the, please don't ever say that. That's irresponsible. It seems to be very common to say that kind of stuff, but it's not, especially the tongue. You have to get a baseball bat to the face in order for that to get ripped. So for children, I'm a little bit more like, let's get it released. It's very low impact. It's very high impact for the first 48 hours. And then after that, it's pretty low. So there's that. For adults, I will see. Some adults are very, very tied, and then we have to get it cut. And some adults are like, can we just see, like this perio guy, he's like, I really just want to solve this perio problem. I don't want to have to go for surgery. He's a naturopath in Wyoming, so he's all, you know, holistic-y. And we were able to solve his problems with just the myofunctional therapy.
And the rugae, how explaining to the patient how if I see that, how it is caused by the tongue not being there.
Yeah, everything in your body gets rubbed down. And when you have your tongue up against the rugae where it belongs, and that's kind of like a, I don't know, a little carpet so that you get some traction in order to swallow. And if your tongue is never up there, they're too sharp. And it's just an indication that the tongue is not up. Are sharp rugae problematic in and of themselves? Not really. They are just an indication that the tongue is not where it belongs.
All right, any other questions? All right, ladies, I hope you learned a lot. I love listening to Shirley. I think this should be mandatory, that we have this education in our repertoire. So excellent. Thank you for joining us. And I hope
everybody.
that you know, I get to see you all in Dallas, or not Dallas, well, in Dallas and in Phoenix. And
Phoenix.
Phoenix. Phoenix is next. And then our October 1st will be our next Earn and Learn CE, and it will be about biofilm and the pathogens that are in the biofilm, namely Porphyromonas gingivalis. And y'all need to know about that. So please join us for that. And any questions, just give me a heads up and we'll get them to Shirley. And please contact Kim and let her know that you have completed the course and that I will send her your name, but also that you need your CE. So please follow up on that. So thank you so much, Shirley.
Yeah.
I enjoyed it immensely. I hope everybody else did. And we'll see you in Phoenix, and then we'll see you again in 2 months on October 1st. All right, everybody. Thank you.